Time for another video in this series about clinical toxicology. We'll be discussing serotonin reuptake inhibitors and atypical antidepressants, which corresponds to Chapter 69 in Goldfrank's Toxicologic Emergencies. The learning objectives for this session are that you'll be able to list the expected clinical effects seen with selective serotonin reuptake inhibitor, or SSRI, overdose, explain the mechanism of action of SSRIs and some typical antidepressants, and be able to outline a treatment plan for serotonin syndrome. Now here's a slide that you can also see in some other video discussions in this series, where I discuss other classes of antidepressants. The history here is that there have been sequential changes in which antidepressant drug class has been most favored. All of these classes, the monoamine oxidase inhibitors, cyclic antidepressants, and SSRIs, are roughly equally effective in treating depression, but we've progressed through drug classes that are increasingly safer in overdose situations, which is a good thing because depressed patients are self-evidently at risk of intentional drug ingestion, and if they have antidepressants on hand, then that's likely what they'd take. SSRIs have a simple mechanism of action that's right there in the name of the drug class. Serotonin is one of a few biogenic amines that act as neurotransmitters that are released into synapses. They combine to postsynaptic serotonin or 5-HT, 5-hydroxytryptamine receptors, and the signal gets turned off by reuptake of the serotonin back into the presynaptic cell. In the presence of an SSRI, that reuptake is blocked, that serotonin reuptake is inhibited. So it sticks around longer in the synapse, resulting in increased serotonergic neurotransmission. And although it's a major simplification to say so, more serotonergic tone leads to improvement of depression. So that's what happens with a pure SSRI. There are some similar antidepressants, the so-called atypical antidepressants, that inhibit serotonin reuptake but also block reuptake of dopamine and/or norepinephrine, and this effect can also help improve depression. Some of the atypical antidepressants covered in the textbook chapter have additional mechanisms of action, like partial serotonin receptor agonism and blockade of histamine and alpha-adrenergic receptors, but the main gist of all of these combinations is to increase synaptic levels of biogenic amines that may help to improve mood. A few slides ago I said that SSRIs are safer than MAOIs and cyclic antidepressants, and on this slide we see some of the data. The SSRI drugs are highlighted in green, with the cyclic antidepressants in yellow and the MAOIs in red. We see that many of the green SSRIs are on the left, representing higher numbers of reported exposures. And virtually all of the green SSRIs have lower hazard factors, the black dots representing life-threatening or fatal outcomes per 1,000 exposures, than seen with the yellow TCAs and red MAOIs. Common signs and symptoms after SSRI overdose include nausea and vomiting, tremor, tachycardia, and drowsiness, and that's usually about it. The most notable exception among the atypical antidepressants, which are combined with the SSRIs on this slide, is bupropion, which has a higher hazard factor than the rest of the green drugs. We'll briefly come back to this later. Serious cardiotoxic and neurotoxic effects from SSRIs can occur, but are rare. This slide shows some of the data from an Australian study of 469 cases of SSRI overdose. 15% of the patients were tachycardic, which might be notable but isn't dangerous, and a prolonged QT interval was fairly frequently seen, although there were no cases of torsade de pointe reported. Seizures or coma occurred rarely in the range of about 2% each, but serotonin syndrome occurred in 14% of cases, about 1 in 7 patients with SSRI overdose. More about serotonin syndrome later. The management of SSRI and atypical antidepressant overdose is largely supportive, as the typical clinical course is pretty benign. Like for all emergency department patients, you start by addressing the ABCs, airway, breathing, and circulation. You may have heard the history in the patient of an SSRI overdose, but you'd evaluate the patient for potential co-ingestions, which is likely to include ordering serum acetaminophen, salicylate, and maybe ethanol levels, and be sure to check the EKG. We'd like to see whether the QRS duration is prolonged, which might be a sign instead of cyclic antidepressant overdose, with cardiac sodium channel blockade, which could change management. It's also possible, yet rare, for an SSRI overdose by itself to cause some sodium channel blockade. And you'd also consider whether any GI decontamination is indicated. In an awake and cooperative patient, you'd probably give oral activated charcoal after a recent drug ingestion. The notable exception to the rule that these overdoses are almost always benign is bupropion. Bupropion is associated with a higher incidence of seizures than the other SSRIs and atypical antidepressants. The formulation of bupropion typically used to treat depression is sold as Wellbutrin in the US. And since it is often in an extended release preparation, the onset of seizures might be delayed many hours. Meaning that I'd prefer to admit these bupropion overdose patients for longer observation instead of just watching them in the emergency department for a few hours and giving them medical clearance for a psychiatric disposition if they've remained asymptomatic or only minimally symptomatic. The next portion of this discussion is a true historical cautionary tale about serotonergic drug interactions and staying up late at night as a resident physician. In 1984, Libby Zion was an 18-year-old freshman at Bennington College in Vermont, and she happened to have a notable father, Sidney Zion, who was a writer, lawyer, and publisher in New York City. In March of that year, she was back home in New York and presented to the emergency department at Cornell Medical Center with complaints of fever, chills, muscle and joint pains, a little bit of agitation, and uncontrollable shaking. Her past medical history included some kind of psychiatric treatment for stress, and that she'd had a recent tooth extraction and earache and had been put on medications for that. The meds she was on were phenelzine, a monoamine oxidase inhibitor antidepressant that is now very rarely used because the MAOIs have been supplanted by the serotonin reuptake inhibitors. She was on oxycodone for the tooth and ear pain, and also erythromycin, a macrolide antibiotic that is a cytochrome P450 3A4 inhibitor. In the emergency department, she was febrile with a temperature of 39.7 degrees centigrade, and she had orthostatic changes in her pulse and blood pressure. If you measured her vital signs while she was lying down, you'd get a certain pulse and blood pressure, but if she stood up, the blood pressure would go down and the pulse would go up as a reflex, and this is consistent with being dehydrated. The assessment was that she had fever, body aches, and was acting a little goofy, and the presumptive diagnosis was that she had a viral syndrome. And they even dared to write down, quote, with hysterical symptoms, unquote, which is a bit judgmental. She looked sick enough that they wanted to admit her to the hospital, but there was nothing specific they thought needed treatment, so she was admitted for observation. They called up her regular doctor in the middle of the night, who agreed with that assessment and plan. She was seen by the intern, a doctor in their first postgraduate year, PGY, of residency, and the second-year resident just before 2 a.m. And then the second-year resident went to the call room to get some sleep. This left the first-year resident caring for 40 patients essentially on her own. This was, and still is, normal at night in an academic hospital. The admitting orders included acetaminophen for fever and meperidine for agitation and shivering. You'll remember that meperidine is a synthetic opioid pain medication that we don't use much anymore, but there is good evidence that it helps attenuate postoperative shivering. Patients get cold in the operating room, and as they are recovering in post-op, they will often begin to shiver uncontrollably in a reflex to generate more body heat. The shivering can be very uncomfortable for the patient, so if you give meperidine, as shown on the graph on this slide, you can reduce the temperature threshold for shivering. The patient is then more comfortable, and you can help heat them back up instead by giving them warm blankets. Libby Zion had this uncontrollable shaking going on, so they thought they could treat this like post-op shivering and give meperidine, just presuming that shivering and shaking are the same thing. And if the meperidine happened to decrease her agitation or pain, then all the better. At 4 a.m., the nurse paged the first-year resident to report that the patient was restless, shaking, agitated, and disoriented. Over the phone, the intern ordered physical restraints, a posy vest, which is a cloth vest that can be tied to the bed and prevent a patient from getting up and then falling down and hurting themselves. And also haloperidol, an antipsychotic, which is also good for sedation. These orders were made without returning to the patient's bedside, and again, this was, and still is, pretty normal. You don't always have the time to go to the bedside before starting orders because there's a lot to do with other patients, and also many things respond well to typical therapy you can give a verbal order for by telephone. The intern was called again when the patient's body temperature, measured in the axilla, which underestimates the core body temperature, was 42 degrees centigrade. This is 107.6 degrees Fahrenheit, and a cooling blanket was ordered, which uses cool water in thin plastic tubes running through a flexible sheet to reduce the fever. The patient had a respiratory arrest 4.5 hours after admission, and she could not be resuscitated. This was kind of a big deal, and it was all over the news. And remember that her father was a lawyer and publisher, and he wrote a lot about this. The drug reaction that is believed to have gone on was a very severe case of serotonin syndrome. She had a monoamine oxidase inhibitor, which increases serotonin levels by blocking its metabolism. Cocaine was also found at autopsy, and that has pro-serotonergic effects by blocking reuptake of biogenic amines. And she was given meperidine, which itself also has pro-serotonergic effects. She probably had serotonin syndrome to begin with, even before the meperidine, but the meperidine made it worse. And erythromycin might have contributed by decreasing the metabolism of some of the drugs that were pro-serotonergic. She was exhibiting a lot of the clinical features of serotonin syndrome, with agitation, tachycardia, autonomic instability, and this uncontrollable tremor, which tends to be worse in the lower extremities compared to the upper extremities. So unfortunately, she was treated for her serotonin syndrome by giving her something that made her even worse. This led to a very high-profile legal case, about which her father wrote, quote, "They gave her a drug that was destined to kill her, then they ignored her except to tie her down like a dog," unquote. In fact, the prosecution tried to pin the residents involved with murder charges, but a grand jury declined to make those indictments, although the case did go to civil court. A New York State commission was created which recommended work hours limitations for resident physicians to no more than 80 hours per week with no shifts longer than 24 hours, which has been a model for creating national standard work hours restrictions ever since. The commission also thought that none of this would have happened if the residents weren't working alone in the middle of the night, so they recommended that an attending physician needed to be present in the hospital. Serotonin syndrome shares a lot of features with NMS, neuroleptic malignant syndrome, which is another drug-induced condition characterized by hyperthermia. These can be differentiated by the acuity of onset after exposure to the drug and what class of drugs it was the patient had been exposed to. And while both syndromes have muscle stiffness or rigidity, there is increased movement with serotonin syndrome due to the hyperreflexia and clonus, but there is decreased movement with NMS. On this slide, we see a table of medications that have been associated with serotonin syndrome, along with their mechanisms of pro-serotonergic action. Serotonin syndrome most often occurs when a patient is exposed to multiple pro-serotonergic drugs at once, although it can occur with larger single-agent exposures, as with SSRI overdose. The agents that are grayed out on this slide have been implicated in serotonin syndrome risks since they have known pro-serotonergic effects, but the documentation that they actually increase the risk is weak. Serotonin syndrome occurs along a spectrum of severity. I'm convinced that lots of people get mild serotonin syndrome, and they feel anxious and have a mild tremor, but they never get bad enough that they need to seek medical care, and it all resolves on its own without needing any treatment. When I've made the diagnosis of serotonin syndrome on patients in the hospital, it's usually in patients who have marked hyperreflexia and clonus, and those would be the moderate cases on this slide. I think that the presence of hyperthermia is a marker of the most severe cases, and I know some toxicologists who don't even make the diagnosis of serotonin syndrome without there being hyperthermia. I think what they're saying is that you don't have a case of serotonin syndrome serious enough to do anything specific or different unless the patient is so sick that they're hyperthermic. And I would agree with that action plan. The only potential disagreement here is about definitions and semantics. Serotonin syndrome is primarily treated with supportive care, but an antidotal therapy does exist, cyproheptadine. Treatment consists of IV fluids, cooling measures if the patient is hot, and sedation as needed. The degree of sedation needed will vary with the degree of agitation and distress noted, and might require fairly heroic doses to get the patient calmed and the neuromuscular hyperactivity toned down. The more the patient is twitching, the more heat they will generate, and the more likely it is they will develop rhabdomyolysis, skeletal muscle breakdown, which can injure the kidneys. IV fluids and maintaining urine output will mitigate that risk. Cyproheptadine is an antihistamine that also has 5-HT1A and 2A blocking properties, so it should help to reverse serotonin syndrome. The trick with cyproheptadine, though, is figuring out how to give it since it's only available in a PO formulation. If the patient is awake and alert enough to take an oral medication, then do they really need it? And if they're sicker, then how would you give it? Probably crushed up and through a nasogastric tube. And in the lower right-hand side, you can take a look at a recommended treatment/sedation algorithm that involves cyproheptadine, benzodiazepines, and even dexmedetomidine, an alpha-2 adrenergic agonist given by IV infusion in ICU settings. And with that, we're done with our video discussion about serotonergic antidepressants and the serotonin syndrome. I'll be seeing you around.